I'm David Lombardo, and this is WCNY's The Capitol Press Room. And we're going to explore the delays New Yorkers experience in trying to access mental health and substance abuse services, which is the subject of a new report from the InUnity Alliance, which represents nearly 200 community-based organizations and professionals providing substance abuse and mental health services. To discuss their findings, we're joined by Jihoon Kim, the organization's president and CEO. Thanks for joining us in the studio.
Thanks for having me, David.
So, citing capacity and insurance requirements, which we'll get to, you found that New Yorkers looking for help with substance abuse and mental health conditions are forced to wait right now. What type of services have a backlog, and is this impacting any communities more than others?
Sure. I mean, we did a survey, right, that was representative of community-based providers across New York State, and we have 50 respondents. And the services that we found at greatest risk were the Assertive Community Treatment Program, the ACT teams, which are, really looked at as the gold standard of serving people with serious mental illness.
What do they consist of?
It consists of outreach teams, care coordination, and real high-intensity services where there are very specific metrics that OMH requires providers to meet in the number of visits per month and the quality of the care that they deliver.
Any other services where there's a wait?
And there are health homes, health home care management, which is a care coordination service for people that are at high risk with mental illness and substance use disorders, as well as the personalized recovery-oriented services, which is a PROS program, which is a pretty standard program that is delivered in Article 30 and OMH licensed programs.
And again, with the understanding that there's maybe some limitations from the survey, any reason to expect that these delays are hitting certain communities more than others? I mean, there are populations that traditionally have had disproportionate waits compared to others, or is this something where you think maybe this is just across the spectrum a problem?
I mean, while it is certainly true that communities of color have fewer resources as it relates to healthcare, generally speaking, as well as mental health and substance use disorder services, for the purpose of our report, we didn't dig that deep, but we did do a representative sample. So the programs and the providers who responded to our survey were from all over the state, downstate, including in like the Bronx and Harlem and different parts of New York City, as well as in rural areas that have different challenges in meeting the needs of their communities, such as the North Country, Watertown, as well as in Western New York.
And what's the significance then of these delays? Is it just that people then decide not to get these services? Is it the problem that their conditions get worse? I mean, what are you hearing or seeing?
So, I mean, it's a combination of what you said. I think the two main things that happen is people either delay treatment and the services that they need, requiring more acute urgent services like crisis services later on. We also know that delayed services leads to increased risk of incarceration, as well as so interaction with the carceral system, as well as increased interaction with the child welfare system for individuals that have children, and hospitalization, which is more costly to go to the hospital for service than a community-based provider for services, as well as death. And in some cases, people just completely forego treatment as a result of delays in getting access to treatment.
Well, let's talk about what's driving these delays. And for starters, I'm thinking about resources, because what you've described are what sound like very labor-intensive, personnel required to treat people. And I'm wondering, is this what the state is investing in, or is the state investing in other types of care, like more institutional settings where maybe you can stretch a dollar further?
So it's a combination of factors. In order to answer that, I do have to paint the picture that we tried to paint in our reports. So, well, I will acknowledge that, especially under the Hochul administration, there have been meaningful investments, both financial as well as in policy changes in behavioral health services. So we are grateful for that, and including the 2.7% targeted inflationary increase, which both the governor and we know the legislature came together to give us more than what the governor introduced in her executive budget.
And that's the cost of living adjustment that you guys need just to keep up with inflation.
Exactly. But with that said, the reality is over the governor's tenure, even though she has had a COLA proposal in each of her budgets since taking office, which we are tremendously grateful for, it still has lagged behind the actual true inflationary increase that providers and anyone is dealing with. Right? It's not just community-based providers that are dealing with increased costs of health insurance and other factors, right, that impact your bottom line. But with that said, at the end of the day, what we saw through this survey is that providers are operating at deficits. They're operating programs despite their organization and specific programs operating at deficits, and that comes from a combination of workforce challenges and the intense services that they provide, and the ratio of clinicians, psychiatrists, nurses that they need to hire in order to run a lot of these programs, like the ACT teams and other programs that I talked about earlier. Organizations are waiting months to get paid, and these are there are two factors here. They're waiting months to get paid from insurance companies, and they're also waiting months to get paid for services already delivered. I have to make that caveat by local and state government, right? There are contracted services that providers have with local and state government, and they deliver these services, they execute on their contracts, and yet they're still waiting months and months to get paid for those services. So what that leads to is organizations having to, borrow against their credit. And we did a survey last year that showed specifically about contract and payment delays. And what we discovered is that on average, from our membership, organizations had about $20 million in contracted payments they were still waiting for from local and state government. When I say local, it's primarily New York City and New York State government. And they also had an average of $90,000 in interest just from borrowing against their credit in order to make payroll, right? So that's another factor that's impacting providers. And then finally, organizations, this was, to me, the most startling but not unexpected result from the survey is they're spending thousands of hours every year just dealing with administrative hurdles, including insurance approvals for people who are coming to get care from their clinics. So we had 22 organizations that kept 39 OASIS licensed programs operating and 81 OMH licensed programs operating, despite those specific programs like ACT Teams, PROS, and Health Homes that I mentioned earlier, operating at a deficit. And they were able, they have to actually piece together other sources of funding, foundation grants, fundraising efforts. I mean, you see all nonprofits. I run a nonprofit now. We have to do fundraisers all the time, right? Golf fundraisers, other fundraisers, award ceremonies, and they're piecing together to be able to just keep these programs alive, basically, so that the people who deserve those services can access those services. One other factor this is the part that was really astounding but not surprising, is 17 organizations spent in one calendar year 41,000 unreimbursed hours just navigating insurance barriers for their program participants. 41,000 hours over 17 providers. I'm not a mathematician, but I did that. It's pretty simple math. In 1 year, each organization spent over 100 days just negotiating for payment or prior authorization denials or other insurance barriers with insurance companies.
And is that dealing with private coverage, or is that dealing with state plans?
This is both Medicaid and commercial insurance.
And is one worse than the other? Or are they both a problem as far as you're concerned that needs to be addressed?
I do think that they're both concerns that need to be addressed. And they're both concerns that need to be addressed in different ways, but there are also some similar things that the state can do to ensure, because there are pretty significant laws on the books about behavioral health parity. Meaning that what insurance companies, cannot, that there needs to be parity between what they're paying for in medical services as there is in behavioral health services, right? So there are laws on the books. It really is about compliance and enforcement. And while, I think the state has done some work there. I mean, if you compare New York to some other states, and it's not just the fines that they're going after insurance companies with, but it's really looking back and peeling back the layers and looking at, are you complying with the laws on the books? And what we saw in New York, what we see right now in New York is that, the regulators, are really, they can do more, right? They can do better.
Well, flesh that out, because the regulatory action is something that might not need statutory authority, so that's something that would be maybe more like low-hanging fruit. What would you want to see regulators do in this space that they're not doing or not doing enough of?
Yeah, I mean, I think, it can get pretty meaty, but I think the way I would kind of highlight it is that there are, OMH and OASIS, I know they work closely with DOH and the Department of Financial Services, DFS, right? DFS regulates the commercial plans, DOH regulates the Medicaid and Medicaid managed care.
And for listeners who weren't familiar with those other acronyms, that's the Office of Mental Health and the Office of Addiction Services and Supports.
Exactly. And when they discover parity law violations, which I won't get into the nuances of that, but there are very specific things that state officials are looking for as to whether insurance companies are following the letter of the law. What I have seen, and this is even in my time in government, what I've seen in working with the agencies is that they may issue citations, right? A warning letter. Whereas I know in my prior years working in the AG's office, the AG would look holistically. If they got a complaint through their healthcare bureau helpline, they got a complaint about some kind of prior authorization denial for behavioral health services, it would get kicked up to an attorney, and the attorney would then go and, the AG has different authority, right? Can go and subpoena and look at records. They would look and see holistically, is X insurance company, right, following the letter of the law as it relates to behavioral health parity. And if they discovered through their investigation that they weren't, they would issue pretty hefty fines, right? But that's like the back end. Like after something has already happened kind of across the board, the AG's office can come in and look and make sure that they penalize and send kind of a warning shot that you can't do this, that this is what the law says. But I think going back to the state regulators, yes, they absolutely, in addition to issuing citations, they absolutely have to be issuing fines that then they have to collect immediately from insurance companies. Because, just think about if you went after a big insurance company, right? I'm not going to necessarily get into the names of individual ones, but we know who some of the bad actors are.
Let's call it Schmigna.
Schmigna Insurance Company, right? And if the state, looking at dozens and dozens and hundreds in many cases of citations that are issued by either the Department of Health or DFS, actually issued fines pretty quickly thereafter, it would send a chill, I think, through the insurance industry that doesn't currently exist in New York.
And after a quick break, we'll continue our conversation about addressing the delays that New Yorkers are facing when accessing mental health and substance abuse services with our guest, Jihoon Kim, the president and CEO of InUnity Alliance, which represents nearly 200 community-based organizations and professionals providing substance abuse and mental health services in the Empire State. And when we get back, we'll talk about changing the current Medicaid system to limit the role of insurance middlemen. And we'll also talk about redirecting state funding in the mental health and substance abuse space, and consider the impact of federal changes on the ability of the state's nonprofit providers to meet the needs of New Yorkers with mental health and substance abuse conditions. Support for the Capitol Press Room comes from O'Donnell and Associates, a public affairs firm providing strategic guidance to businesses and nonprofits on navigating policy and regulatory issues. More information is available at o'donnellsolutions.com. This is WCNY's The Capitol Press Room, and we're continuing our conversation with Jihoon Kim, President and CEO of InUnity Alliance, which recently published a report on the delays New Yorkers are facing when trying to access mental health and substance abuse services. We'll pick up our conversation with the ongoing campaign by nonprofit providers in the space to get carved out from the current Medicaid system, which they argue is benefiting insurance middlemen at the expense of frontline organizations.
We truly believe that the experiment over the last decade of the managed care carve-in for behavioral health services has utterly failed, and it has failed on multiple fronts, but I think most importantly has failed in delivering for New Yorkers who have that insurance and can't even access services as a result. And as you asked me before, then what happens? People either delay services, it becomes more costly for the state ultimately. They unfortunately die in many cases as an overdose or suicide, and some just completely forego treatment altogether.
Well, I want to come back to the issue of available resources to the providers that you represent, because we think about budgeting in a zero-sum game because there's only a finite amount of money to go around. Are there programs or initiatives that you'd want to take from that you think maybe they're not overfunded, but maybe you get more bang for your buck by serving your providers, and maybe the increase in COLA will have more of effect for you than an institutional setting, or by spending money on your community-based organizations, you ultimately can save money on something else?
What we've seen the state do is the state has invested, especially under Governor Hochul, in behavioral health services. And what we've seen come out of that are a lot of these RFPs that OMH is putting out for new services. What we are hearing from providers is that we are struggling right now to maintain and keep operating the programs that we're already getting money for, but underfunded, contracted to provide, over many years. This is less about what should providers think about doing in alternatively to the services that they're all already offering, or like are organizations going to take from one program to sustain it? They're already doing that in many cases, right? When I said the specific programs that are operating a deficit, they keep running them, and in many cases they're able to do that because they do have other books of business, right? And they are able to ultimately balance their budget. However, at the end of the day, that's not a sustainable model, right? So I think it's a long-winded answer to your question, but I do think that what the state really needs to look at is they have the data. OMH and Oasis, they know, they are able to look at claims, they are able to look at the financial viability of their licensed programs. They really need to look at programs that are struggling. And in many cases, we hope our report highlights some of those very specific programs for the state and say what is not working with these programs and what can we do better. One example is the ACT teams, right? The ACT teams, again, is the gold standard. Right?
And remind us what they are.
It's the assertive community treatment teams. And they really work with the highest risk individuals of serious mental illness. And in many cases, a lot of ACT programs are dealing with people who who are just coming out of incarceration. OMH has launched forensic ACT teams to specifically deal with people who have interaction with the criminal legal system. And really, I think, for the listeners, it is dealing with the highest risk population of New Yorkers. And there have been many stories and profiles about this in different media spaces about, every time there's some kind of incident, people look to see if this person had an ACT team, right? If they were assigned an ACT team, right? So OMH continues, and I understand why they do it. I mean, I worked for the governor, I worked for the state. I understand why they continue to pour resources and new money into new ACT teams. But that's like building a new house on a very shaky foundation, right? The foundation of, I call them legacy ACT providers, but these are ACT teams that are already on the ground, right? And some have for decades. When those providers are really screaming from the rooftops saying, the model is not sustainable, our rates are not sustainable, we need regulatory flexibility to better meet the needs of New Yorkers who have different behavioral health needs today when they signed the contract with OMH decades ago, right? Acuity is higher. If you ask any clinician, the acuity, the struggle of New Yorkers dealing with serious mental illness has, increased significantly. It's not just the quantity, it is actually the experience that New Yorkers are having. It has increased. And when you think about, program models where you have to have 6 clinicians on staff, 2 psychiatrists, et cetera, and you're given the same amount of money to deal with a population that has increased behavioral health concerns and needs, it just doesn't add up. Like, it doesn't work that way.
Well, let's layer on top of that the federal government and the policies emanating out of Washington, D.C. Are they improving or complicating or making all of this worse?
Yeah, I mean, it is making it worse. I mean, one layer of this is what has already happened, right? And what has already happened, and we're grateful that some of the things that happened did not happen anymore. Like I call it the Midnight Massacre. The Trump administration abruptly canceled hundreds of millions of dollars of SAMHSA funds, discretionary funds that were going to community-based behavioral health providers in January. There was uproar from, Democrats and Republicans in Congress, so they restored it. But that was just emblematic of what community-based providers with SAMHSA funding have been dealing with over the last, year plus since Trump has taken over, has become president. And one consequential thing that happened last year that, that kicked the can down the road is HR 1, right? It's the OBBB. I won't call it by what, the Republicans call it.
The one big beautiful bill,
yes.
If you know it that way.
And they made some significant policy changes in that, specifically to people on Medicaid, and as well as other health insurance changes. One is on July 1, there are going to be, New York estimates 450,000 New Yorkers who are enrolled in the Essential Plan who are going to lose coverage on the Essential Plan, right, which kept it very affordable, right, with no premiums for individuals on the Essential Plan. A lot of those individuals, while they're not the same population that I'm going to talk about with the Medicaid changes coming up, some of them will be the same population, right? But a lot of those individuals, yes, can they qualify for something on the healthcare marketplace? Yes, they can qualify, but the real question is, can they afford to pay those premiums for the insurance on the healthcare marketplace? I mean, I know personally people who have gotten those letters and are looking on the marketplace and they cannot afford it, right? And I mean, hopefully there will be enough employer-sponsored insurance coverage for individuals to be able to at least have no gap in healthcare coverage. But that is a tremendous risk for people with behavioral concerns. I think the bigger risk that is coming is in January of 2027, when we're going to see more frequent Medicaid recertification. It will be every 6 months instead of every 12 months, right, for people who have Medicaid. And work requirements, right, will go into effect for individuals who are on Medicaid. And this is kind of like a live issue right now because the federal government, CMS, just issued a draft interim final rule last week, which was very meaty. It was 400 pages. But as I've been talking to folks who are much smarter than I on those federal issues, we are concerned, and we need to make sure that the state government implements as flexibly as possible for New Yorkers who have behavioral health concerns, the ability to meet those work requirements or be exempt from those work requirements, as well as for New York State to be able to implement a pretty seamless, and I'm being optimistic that they'll be able to implement a pretty seamless recertification process for individuals. I mean, if you think about people who are on Medicaid, there are a lot of people and who go to behavioral health clinics who may be in between permanent residences, who may be living in a homeless shelter, right? These are individuals who are expected to keep track of their Medicaid recertification date and expect a letter from the state saying you have to recertify. What if they do not have an address where they can be easily reached, right?
I mean, your providers are going to be tasked with recertifying.
Well, that's exactly what it is. So I'm glad you said that, David, because right now that's what providers are doing. Providers are doing a lot of uncompensated work right now, meaning all these things that they're doing with their client and with their clinician time as administrative staff time is not reimbursed by these contracts that I said are already delayed and insufficient to meet the needs. So I think on the Medicaid issues, people are going to lose coverage. There are going to be an inordinate amount of people who lose coverage in New York. And I think a particular risk are people with behavioral health concerns, who I said, who have unstable housing. And as providers try to on the ground interact with these individuals to ensure that they do not lose coverage, some of them will. And what we've seen with community-based providers in the behavioral health space is, one, there are certain programs that they have to deliver services even if the person loses their insurance coverage, like certified community behavioral health clinics, which is an integrated clinic model between OMH and OASIS with an enhanced reimbursement rate. Those clinics are required to serve individuals regardless, right, of insurance status. So they are going to have uncompensated care that will really balloon in the coming year. So one of the things that we would love to see the state do, and we've talked to both state OMH and OASIS about this, is ensure that they invest in an expanded indigent care pool, which would allow providers to be able to account for these uncompensated services that they're going to be delivering. There are already indigent care pools in a lot of programs, but there just isn't enough. We need a separate one just for behavioral health community-based organizations. I know the hospitals have indigent care pools, and we're kind of going to be in this, muddy water of everyone asking for more funding to help with all these issues that I'm talking about. And we are going to be advocating that the state, look into creating an expanded indigent care pool specifically for organizations that provide behavioral health services.
Well, we've been speaking with Jihoon Kim. He's the president and CEO of the InUnity Alliance, which represents nearly 200 community-based organizations and professionals providing substance abuse and mental health services. Jihoon, thank you so much for making the time.
Thanks for having me.
Support for the Capitol Press Room is provided by New York State United Teachers, a statewide union of nearly 700,000 professionals in education and healthcare.